I'm an infectious disease specialist who spent 21 years at Riverside Memorial Hospital in Seattle, Washington, dealing with everything from antibiotic-resistant superbugs to emerging viral threats that crossed international borders. You can call me Dr. Elena Vasquez, but what I'm about to tell you is the one outbreak that made me question everything I thought I knew about how diseases spread, how pathogens behave, and ultimately forced me to leave epidemiology forever. Riverside Memorial is one of the premier medical facilities in the Pacific Northwest, with a specialized infectious disease unit that handles the most complex and dangerous pathogen cases from across Washington, Oregon, and Northern California. During my career there, I've tracked down sources of multi-state food poisoning outbreaks, managed hospital-acquired infections that threatened entire wards, consulted on potential bioterrorism threats following suspicious white powder incidents, and dealt with every imaginable way that microscopic organisms can devastate human lives. I've seen Ebola patients airlifted from West Africa, managed SARS cases during the early 2000s outbreak, and tracked the spread of H1N1 through nursing homes, where every hour counted in preventing mass casualties. I've worked with teams from the CDC, collaborated with international disease surveillance networks, and published over 40 peer-reviewed papers on emerging infectious threats. In 2 decades of practice, I thought I had encountered every possible way a pathogen could surprise the medical community. The case I'm about to describe began in a way that seemed almost routine, the kind of small-town outbreak that might warrant a brief investigation and a standard epidemiological report. But it would evolve into something that challenged every principle of infectious disease medicine I'd learned during my education at Johns Hopkins and my subsequent years of field experience tracking diseases across 3 continents. What happened in the small coastal town of Millbrook Bay would not only defy medical explanation, but would ultimately drive me to question whether our fundamental understanding of how diseases work is as complete as we believe it to be. It started on September 22, 2019, in the small coastal town of Millbrook Bay, Oregon, population 1,243, nestled between the Pacific Ocean and the Cascade foothills about 85 miles southwest of Portland. Millbrook Bay was the kind of place where tourism from Portland and Eugene kept the economy alive during summer months, where everyone knew their neighbor's business, where the biggest excitement was usually the annual Salmon Festival, and where the local clinic saw maybe 5 or 6 patients on a busy day. Dr. Catherine Brennan had been the town's only physician for 12 years, having moved there after completing her family medicine residency in Portland. She knew virtually every resident by name, had delivered most of the children born in the past decade, and prided herself on maintaining the kind of personal medical relationships that had become rare in modern healthcare. That Sunday morning, Dr. Brennan received a call that would set everything in motion and ultimately draw me into the most perplexing case of my career. The call came from Marcus Webb, a 43-year-old charter boat captain who lived with his wife and teenage daughter in a modest house overlooking the harbor. "Dr. Brennan, something's wrong with Rebecca," Marcus said, his voice tight with worry. "She collapsed about an hour ago. She's burning up with fever, and she's got these red spots all over her arms and chest. She was completely fine yesterday. We went hiking up at Beacon Point, had dinner together, watched a movie, but this morning, she can barely stay conscious." Rebecca Webb was a 39-year-old marine biologist who worked for the Oregon Department of Fish and Wildlife, conducting water quality assessments and fish population studies along the coast. She was known throughout Millbrook Bay as someone who was almost never sick, who spent her days outdoors in all kinds of weather, and who maintained the kind of robust health that comes from an active lifestyle and strong constitution. Dr. Brennan immediately drove to the Webb house, expecting to find a case of severe flu, or perhaps food poisoning that had escalated rapidly. What she found when she examined Rebecca was unlike anything she'd encountered in her medical career. Rebecca's fever registered 104.7 degrees Fahrenheit on Dr. Brennan's digital thermometer. More concerning was the distinctive rash that covered her upper body, not the typical viral exanthem she might expect with a high fever, but a specific pattern of raised dark red spots that seemed to follow the path of major blood vessels. Rebecca was semi-conscious, responsive to questions, but clearly disoriented and struggling to focus on conversations. Most alarming was the speed of onset that Marcus described. According to him, Rebecca had gone to bed at her usual time of 10:30 p.m. the previous evening. After a normal day of work and family activities, she'd eaten the same dinner as the rest of the family, hadn't traveled recently, and had no known exposures to unusual substances or environments. Yet by 7 a.m., she was in severe distress with symptoms that suggested a serious systemic infection. Dr. Brennan stabilized Rebecca with IV fluids and fever-reducing medications, then immediately arranged for helicopter transport to Riverside Memorial Hospital in Seattle. But even as she was coordinating the medical helicopter, her pager began beeping with additional emergency calls. The second call came from Diane Foster, whose husband James had been found unconscious in their pottery studio with identical symptoms, the same aggressive fever, the same distinctive rash pattern, the same rapid onset from apparent good health to severe illness overnight. James Foster was a 51-year-old artist who had moved to Millbrook Bay 5 years earlier to focus on his ceramic work, selling his pieces to tourists and through galleries in Portland. Within 30 minutes of the Foster call, Dr. Brennan received a third emergency. Angela Martinez, a 35-year-old veterinary technician who worked at the regional animal clinic, had been brought to the medical center by her girlfriend after collapsing at their apartment with the exact same constellation of symptoms. By 2 p.m. on September 22nd, Dr. Brennan had 7 patients with identical presentations: Rebecca Webb, James Foster, Angela Martinez, followed by Patricia Chen, a 44-year-old insurance adjuster, Timothy Rodriguez, a 38-year-old Forest Service ranger, Michelle Thompson, a 42-year-old library director, and David Kumar, a 46-year-old restaurant owner. Dr. Brennan had practiced medicine long enough to recognize when she was facing something beyond her expertise and resources. The rapid spread of identical symptoms, the severity of the presentations, and the complete lack of obvious connections between the victims pointed to either a highly contagious pathogen or some kind of environmental exposure that could threaten the entire community. That's when she called me. I received Dr. Brennan's call at 3:23 p.m. while I was reviewing preliminary data from a multi-state investigation of antibiotic-resistant tuberculosis cases. The urgency in her voice immediately caught my attention, and the clinical details she provided made it clear that Millbrook Bay was facing a potential public health emergency. Dr. Vasquez, I need immediate assistance. I've got what appears to be an aggressive outbreak of something I've never encountered before. 7 patients, all previously healthy adults, all presenting with identical symptoms that developed overnight. The fever spikes are dangerous, the rash pattern is unlike anything in my experience, and I'm concerned we're looking at either a bioterrorism event or an emerging pathogen. I immediately activated our emergency response protocol. Within 2 hours, I had assembled a team consisting of Dr. Michael Chang, our senior epidemiologist, Dr. Sarah Williams, our lead microbiologist, Dr. Robert Martinez, our environmental health specialist, and a logistics coordinator to manage the complex process of investigating a potential outbreak in a remote location. During the drive from Seattle to Millbrook Bay, I reviewed everything Dr. Brennan had been able to document about the cases. The symptom profile was deeply concerning: explosive onset, dangerously high fever, all patients registering between 104 to 105 degrees Fahrenheit, a distinctive spotted rash that followed vascular patterns, respiratory complications in 3 of the 7 patients, and rapid progression to altered mental status despite aggressive supportive care. My initial differential diagnosis included several terrifying possibilities. The rapid onset and fever suggested bacterial meningitis or sepsis, but the rash pattern wasn't typical for either condition. The overnight development reminded me of toxic shock syndrome, but again, the clinical presentation didn't match perfectly. The possibility of viral hemorrhagic fever crossed my mind, but the geographic location and patient profiles made that unlikely. Most concerning was the possibility of intentional biological contamination, the kind of scenario that keeps infectious disease specialists awake at night. The drive to Millbrook Bay takes about 2.5 hours under normal circumstances, winding through the Cascade foothills and then descending toward the coast, through dense forests of Douglas fir and western hemlock. Under different circumstances, it would have been a beautiful autumn drive, but knowing that 7 people were fighting for their lives with an unidentified pathogen made the journey feel interminable. When we arrived in Millbrook Bay at 6:45 p.m., I found a scene that confirmed my worst fears about the outbreak's potential severity and complexity. Dr. Brennan had converted the town's small medical clinic into a makeshift emergency treatment center, with additional space secured at the community center next door to accommodate the multiple patients and their families. 7 patients lay on a combination of hospital beds, examination tables, and cots that had been transported from the regional hospital. All were receiving IV fluid support, and 3 were on supplemental oxygen. The scene was controlled but tense, with family members maintaining bedside vigils, and Dr. Brennan moving constantly between patients, monitoring vital signs and adjusting medications. What struck me immediately was the random nature of the patient selection. These 7 individuals represented a cross-section of Millbrook Bay's small community, but they had no obvious epidemiological connections that would explain a common source exposure. Rebecca Webb, the marine biologist, spent her days collecting water samples and conducting field research along the coast. James Foster, the potter, worked primarily in his private studio and had limited contact with the public. Angela Martinez worked at the veterinary clinic, but lived on the opposite side of town from most of the other patients. Patricia Chen worked remotely as an insurance adjuster and rarely left her home office. Timothy Rodriguez covered vast areas of forest land as a ranger, often working alone for days at a time. Michelle Thompson managed the small town library, a job that involved regular but limited public contact. David Kumar owned and operated a small restaurant that catered primarily to tourists, but it was late September, well past the peak tourist season. The ages of the patients ranged from 35 to 51, with an almost even split between men and women. Some were lifelong residents of Millbrook Bay, while others had moved there within the past few years. They attended different churches, shopped at different stores, and had different social circles. The randomness made identifying a common exposure extremely challenging. Dr. Brennan walked me through each case, providing detailed timelines of symptom onset and progression. In every instance, the pattern was identical. Patients had gone to bed feeling completely normal and had awakened in severe distress, or in several cases, had been found unconscious by family members. Dr. Vasquez, she said, as we completed our initial assessment, in 12 years of practice here, I've never seen anything spread this quickly or present this aggressively. These are people I know personally. I delivered Angela's partner's children. I've treated David's diabetes for years. I've been Rebecca's physician since she moved here. They're all healthy, active people, with no underlying conditions that would predispose them to severe infections. Over the next 48 hours, my team and I conducted what would become one of the most comprehensive epidemiological investigations of my career. We established a command center in Millbrook Bay's community center, set up communication links with state and federal health agencies, and began the systematic process of identifying the source and nature of the outbreak. Our first priority was collecting biological samples from all 7 patients for comprehensive pathogen testing. Blood cultures, respiratory secretions, urine samples, and skin swabs were collected and prepared for transport to our Level 3 biosafety laboratory in Seattle. We also collected samples from family members and close contacts to determine if the pathogen was actively spreading within the community. Simultaneously, we began the painstaking process of mapping each patient's activities over the previous 2 weeks. We interviewed family members, co-workers, friends, and anyone who had significant contact with the victims. We documented their food consumption, their travel patterns, their work activities, their recreational pursuits, and any possible exposures to chemicals, animals, or environmental hazards. Dr. Martinez, our environmental specialist, began testing water supplies, air quality, soil samples from areas where patients had spent time, and any potential sources of toxic exposure. The restaurant where David Kumar worked was immediately closed for comprehensive testing of all food preparation areas, storage facilities, and cooking equipment. Dr. Chang worked with local authorities to create detailed maps showing the geographic distribution of cases, the timeline of symptom onset, and any potential common exposure points. Dr. Williams coordinated the complex laboratory testing process and maintained communication with CDC laboratories that were standing by to assist with identification of exotic pathogens. What emerged from our initial 48-hour investigation was a pattern that defied conventional epidemiological logic. Despite exhaustive interviews and environmental testing, we could not identify a single common exposure among all 7 patients. They had not eaten at the same restaurants during the relevant time period. They did not shop at the same stores, attend the same events, or visit the same recreational areas. Their water sources were different. Some relied on municipal water, others had private wells, and several used combination systems. Air quality monitoring showed no unusual atmospheric contaminants. Soil testing revealed nothing abnormal in areas where patients had spent significant time. Most puzzling was the geographic distribution of the cases, rather than clustering around a single point source, as we might expect with environmental contamination, or following social networks, as we might see with person-to-person transmission. The cases appeared to be randomly scattered throughout Millbrook Bay, with no discernible pattern. By September 25th, preliminary laboratory results began arriving from our Seattle facility, and each negative result deepened the mystery surrounding the outbreak. Blood cultures showed no evidence of bacterial growth. After 48 hours of incubation, viral panels tested negative for influenza A and B, respiratory syncytial virus, adenovirus, parainfluenza viruses, and human metapneumovirus. More comprehensive testing ruled out exotic viral pathogens, including hantavirus, West Nile virus, dengue fever, and even hemorrhagic fever viruses that would have required immediate CDC intervention. Bacterial testing eliminated possibilities ranging from common streptococcal and staphylococcal infections to more exotic organisms like plague, tularemia, and anthrax. Toxicological screening of blood and urine samples revealed no evidence of heavy metal poisoning, pesticide exposure, or contamination with industrial chemicals. Comprehensive drug screens were negative for both therapeutic medications that might cause adverse reactions and illicit substances that could explain the symptoms. Dr. Williams called me on the evening of September 25th with results that were as frustrating as they were medically significant. "Elena, I've been running clinical laboratories for 15 years, and I've never seen a case series like this. We've tested for over 200 different pathogens, and everything is coming back negative. It's as if these patients developed severe systemic infections without any identifiable infectious agent." The environmental testing was equally puzzling. Water samples from all possible sources showed normal bacterial counts and no evidence of viral or chemical contamination. Air quality measurements were within normal ranges for all monitored pollutants. Soil samples from the patients' homes, workplaces, and recreational areas revealed nothing unusual. Food testing presented a particular challenge because the patients had consumed meals from dozens of different sources over the relevant time period. But comprehensive testing of available samples found no evidence of bacterial contamination, viral presence, or chemical adulteration that could explain the outbreak. While we struggled to identify the cause of the outbreak, the 7 patients were experiencing a disease progression, unlike anything documented in the medical literature. Rather than following the typical course of improvement or deterioration that we might expect with most infectious diseases, their conditions seemed to cycle unpredictably between apparent recovery and severe relapse. Rebecca Webb, who had been the first patient identified, would spend hours appearing to recover. Her fever would break, her mental status would clear, and she would be able to carry on normal conversations with her family. But within 8 to 12 hours, she would spike another dangerous fever. The rash would intensify, and she would again become disoriented and semi-conscious. This cycling pattern was identical across all 7 patients, but the timing was not synchronized. While Rebecca might be experiencing a period of apparent recovery, James Foster could be in the throes of a severe fever spike, and Angela Martinez might be somewhere in between. It was as if each patient's immune system was fighting the same battle on its own timeline. Dr. Amanda Torres, The critical care specialist we had brought in from Seattle was as mystified by the clinical progression as I was by the epidemiological puzzle. "Elena, I've managed thousands of severely ill patients, and I've never encountered a disease that seems to toy with patients this way. It's like whatever is causing this allows them to recover just enough to give families hope, then strikes again even harder." The psychological toll on the patients' families was enormous. Marcus Webb described the emotional roller coaster of watching his wife seem to recover, only to relapse into delirium hours later. "Doctor, it's like she's fighting some kind of battle that we can't see. She'll be talking normally, asking about work, worrying about paying bills, and then suddenly, it's like someone throws a switch, and she's burning up with fever again." James Foster's wife Carol expressed similar frustration and fear. "He'll be completely lucid, making jokes with the nurses, asking me to bring him his sketchbook so he can work on pottery designs. Then 4 hours later, he doesn't recognize me and his temperature is 105 degrees. How is that medically possible?" By September 27th, 5 days after the outbreak began, I made the decision to expand our investigation to include the entire population of Millbrook Bay. Working with state health officials and local authorities, we implemented a voluntary health screening program for all 1,243 residents. The screening process involved temperature checks, basic symptom questionnaires, and blood draws for anyone who reported feeling unwell or had any contact with the affected patients. We set up screening stations at the school, the community center, and the fire station to make participation as convenient as possible. Over 2 days, we screened 1,187 residents, an impressive 95% participation rate that reflected the community's concern about the outbreak and their cooperation with public health measures. The results were both reassuring and puzzling. No additional cases were identified, and no one showed any early signs of developing the distinctive constellation of symptoms that had affected the original 7 patients. Blood samples from healthy residents showed no evidence of exposure to whatever pathogen or agent had affected the original patients. This finding was crucial because it suggested that the outbreak was not spreading person to person through the community, but it also deepened the mystery of how exactly 7 people had been exposed to the same agent without any identifiable common source. We also expanded our environmental testing to include areas throughout Millbrook Bay that we hadn't initially considered. The harbor where Rebecca Webb conducted her research, the hiking trails where several patients had spent time, the beach areas where tourists and residents gathered, and even the small airport where private planes occasionally landed, were all subjected to comprehensive environmental sampling. Additionally, we brought in specialists from the Oregon Department of Environmental Quality to test for industrial pollutants, agricultural chemicals, and any other environmental hazards that might not have been detected by our initial screening protocols. On September 28th, Dr. Jennifer Walsh from the CDC's Epidemic Intelligence Service arrived in Millbrook Bay with a team of federal epidemiologists and laboratory specialists. Dr. Walsh had investigated outbreaks on 4 continents, including Ebola outbreaks in West Africa and most cases in the Middle East. Her presence indicated that our local outbreak had attracted national attention and concern. "Dr. Vasquez," she said during our initial briefing, "the clinical and epidemiological profile you've documented here has some very concerning features that we haven't encountered before. The rapid onset, the cycling fever pattern, the absence of any identifiable pathogen, and the lack of person-to-person transmission create a combination of factors that doesn't match any known disease entity." The CDC team brought additional laboratory capabilities, including testing for biological warfare agents, exotic pathogens that required maximum containment facilities, and environmental contaminants that were beyond the scope of our regional laboratory capacity. They also implemented enhanced surveillance protocols, including daily monitoring of all residents for any signs of illness, expansion of environmental testing to include areas within a 50-mile radius of Millbrook Bay, and coordination with international health agencies to determine if similar outbreaks had been reported elsewhere in the world. Over the following 72 hours, even the CDC's extensive testing capabilities failed to identify any causative agent. Results came back negative for every biological warfare agent in their database, every exotic pathogen they tested for, and every environmental contaminant that could theoretically cause the observed symptoms. Dr. Walsh confided to me on October 1st that in her 15-year career investigating outbreaks worldwide, she had never encountered a case that so completely defied identification. "We've ruled out everything we can think of to test for," she said. "At this point, we're either dealing with a completely novel pathogen that we don't have tests for, or we're looking at some kind of disease mechanism that challenges our basic understanding of how illnesses develop and spread." By October 2nd, 10 days after the outbreak began, we had conducted one of the most thorough epidemiological investigations in the history of Oregon public health. We had tested for over 300 different pathogens, analyzed hundreds of environmental samples, interviewed virtually every resident of Millbrook Bay, and consulted with specialists from around the world. Yet we were no closer to understanding what had made 7 healthy adults simultaneously ill with identical symptoms, or why the outbreak seemed to have stopped as mysteriously as it had started. No new cases had appeared since September 22nd, despite the fact that we had not implemented any specific containment measures or identified any source to eliminate. The patients themselves remained trapped in their inexplicable cycles of improvement and relapse. Each day brought periods of apparent recovery that gave families hope, followed by severe deteriorations that reminded everyone how serious their conditions remained. Sarah Williams, our microbiologist, summed up our frustration during one of our evening briefings. "Elena, we've applied every tool of modern diagnostic medicine to this outbreak. We've used the best laboratory facilities in the country, consulted with experts internationally, and conducted the most comprehensive investigation I've ever been part of, and we're still left with the medically impossible situation of 7 people with identical severe illnesses caused by absolutely nothing we can identify." The residents of Millbrook Bay were growing increasingly anxious as news of the mysterious outbreak spread beyond their small community. Media attention was intensifying, with reporters from Portland, Seattle, and even national news organizations requesting interviews and information about the unexplained coastal plague, as one particularly sensational headline described it. Dr. Brennan, who had been working around the clock since the outbreak